Welcome back, everyone. Today we begin our most crucial chapter in the entire EMT curriculum, and that's going to be Chapter 6, the human body. So whether you're assessing traumas, managing medical emergencies, or just understanding how to document your findings in the field, having a deep, profound understanding of human anatomy, physiology, and pathophysiology is really foundational. Okay, it's going to allow you to understand what's going wrong and what interventions might actually save a life. So now you may hear the phrase knowledge of anatomy and physiology. You're going to hear it so often that it's going to actually start to lose its meaning. But you really have to understand that as an EMT, you're often going to be the first to interpret a set of symptoms and be the one in the role of having to do decisive action. Okay, so knowing where to palpate a pulse, how to identify breath sounds, and where the internal organs that lie beneath the surface landmarks, it's not just academic, right? It's the difference between catching internal bleeding or simply missing it. Anatomy at its core is really the study of structure, okay? So it's what things are called and where they are. Physiology, on the other hand, is how those structures really function together to sustain life. And then you have pathophysiology. Okay, this is a word you're going to hear fairly often in this course and in medicine in general. And this is going to describe what happens when normal function is disrupted by disease or by injury. So this chapter is really going to take us through all the different lenses, okay? Think of this lesson as a guided tour through the system of the body, right? So all the systems from the framework of bones and muscles that let us move and it's going to protect our organs to the systems that allow us to breathe, to circulate blood, digest food, eliminate waste, and reproduce. So by the end, you'll not only be able to name parts of the body, you'll understand their function, how they work together, and what it means when they don't. We're also going to emphasize just how this knowledge will directly translate to EMS care. You'll be better prepared to assess, intervene, and report critical information to the nurses, the physicians, and any other provider in such a way that's going to earn their confidence and it's going to improve patient outcomes. So let's go ahead and get started. And remember, this chapter really forms the foundation for nearly every skill, every assessment, and decision that makes up being an EMT. So let's go ahead and get started. And again, we're going to start with the national standards and move on from there. So before we get into the anatomical details, we first got to talk about this content and what does it prepare you to do. So the preparatory standard really emphasizes your responsibility as an EMT to not only provide emergency medical care, but really to do so with a deep awareness of safety, wellness, legal and ethical responsibilities. When we say preparatory, we mean the essential baseline knowledge that's going to underline everything else. Anatomy, physiology, pathophys, and really your own well-being. So think about it like this: you're dispatched to a scene. Maybe it's a rollover, TC, or a patient who's down in a confined space. Understanding, where the liver or the spine is located is important. But so is knowing how to protect yourself, recognize environmental hazards, and act really within the scope of practice and local protocols. So ethical dilemmas like whether a confused patient can refuse care or legal situations like mandated reporting all depend on the foundation that this section is really going to cover. So if you don't understand how the body is supposed to work and how EMS really fits within the larger healthcare and legal system, you won't be able to make safe and informed decisions. Okay, so this preparatory competency ensures that you're ready, not just to intervene, but to do so with confidence, with professionalism, responsibility. So let's go ahead and move on to the next layer, and this is going to be more about this competency is more about the emphasis of just understanding the structure and function of every major body system, okay, and how to apply that understanding of the body to your patient care. So you need to know more than just what the heart looks like or how many lobes are in the lungs. You must understand how the heart's pumping mechanics really drive perfusion and how oxygen crosses the alveolar membrane into the capillaries, and just how impairments like pulmonary edema or an MI can disrupt those processes. So really it's not just about memorizing terms, it's about the clinical application, right? So if you encounter a patient who's pale, cool, weak distal pulses, your knowledge of systemic vascular resistance and cardiac output helps you interpret those signs. So you're really not expected to be a cardiologist or a pulmonologist. You are expected to know enough to recognize when the body is in crisis and take appropriate actions. So this competency also directly supports your communication with higher level providers. So because when you describe a patient with signs of hypoperfusion and possible chest wall trauma, you're using shared language that's going to connect seamlessly with doctors, these nurses, the paramedics. So mastering this section is how you can elevate yourself and your EMT skills from simply a task-based reactions to more evidence-informed decision-making, all in the field, okay? So now, pathophysiology, okay? So this is where it kind of all comes together. This is the study of what happens when normal function is disrupted by trauma, by disease, by some sort of internal failure. And it's arguably the most critical of the three competencies when it comes to just overall quality patient care. As an EMT, we deal with failure, airway obstruction, inadequate perfusion, respiratory compromise, and shock. You need to understand that the underlying mechanisms of these conditions, to recognize them early and to intervene effectively. So an example, if a patient is in compensatory shock, you might see tachycardia, cool and clammy skin. So that in and of itself is a sympathetic nervous system response, right? Your SNS is working to preserve perfusion to the brain and to the heart, so the vital organs. But if you don't understand that compensatory mechanisms, you might miss the early window for treatment. Similarly, like knowing that a traumatic brain injury can cause an increasing intracranial pressure, and that this pressure really impairs respiratory, cardiovascular regulation via the medulla. It helps you understand why a patient with a head trauma might suddenly become bradycardic or have irregular breathing. So this knowledge is what allows you to anticipate deterioration, prepare your interventions, and really communicate clearly during your handoff. So really, in short, the pathophys is the bridge between your observations and your actions. So when something looks wrong, this competency gives you essentially the roadmap to understand why and what to do about it. So now let's kind of just dive straight into it. So as we kind of dive into the human body, it's really important to know why this material is not just for academic reasons, right? But it's absolutely essential to your everyday practice as a medical provider. So this chapter is a foundation of your clinical knowledge. So without clear understanding of anatomy, with physiology, pathophysiology, you're kind of operating without a roadmap, right? When a patient presents with pain, shortness of breath, altered level of consciousness, it's your understanding of what's supposed to be happening in the body that's going to allow you to identify what's wrong. Anatomy tells us what's there, right? Physiology is going to explain how it's supposed to work. Pathophysiology shows us how and why it kind of breaks down. So these three domains work together to help you form what we call field impressions, prioritize your care, and really explain your findings in clinical terms to a receiving hospital. So this really isn't just about memorization, it's about pattern recognition, decision making, and communication. In the field, when you don't have time to second guess yourself, you understand your understanding of how the body works becomes your most valuable tool. Again, for example, when you hear shortness of breath and chest pain, do you think the lungs, the heart, a rib fracture? Without the foundational knowledge, you're kind of just flying in blind. But with it, you become a professional who's able to intervene with purpose, right? This chapter is going to prepare you for that. It trains your clinical brain to see not just symptoms, but rather systems. So not just what hurts, but why. And ultimately, what can you do to actually help? So when we talk about the human body, right, in EMS, we must speak in a shared language, okay? One that really leaves no room for confusion at the scene, okay? The language begins really with anatomic position, okay? Picture a person standing upright, facing forward, arms at the side with the palms facing out. This is the universal reference point for all anatomical terms. No matter how the patient is actually positioned, prone, seated, crumpled in an erect vehicle, we mentally place them in this position when describing injuries. So when we say something is lateral or proximal, we're using the anatomic position really to orient ourselves. It ensures that when I say a wound is on the anterior aspect of the forearm, the nurse, trauma surgeon, and even the documentation specialist understand exactly what I mean. There's just gonna be no guesswork, okay? Memorize this position because it's really the foundation for every directional term and every injury report you're ever gonna give in the field. So when we describe these injury locations, right, in anatomic position, we're going to perform physical assessments, document what we find. We often rely on what we call imaginary divisions called anatomical planes, okay? And this is going to organize and reference regions of the body. These planes are really essential tools that help healthcare providers communicate really with precision, right? There are three primary planes and one kind of important subtype, okay? That's going to divide the body into sections for descriptive and diagnostic purposes. So let's begin with the coronal plane. It's also known as the frontal plane. This vertical plane is going to split the body into front and back portions, right? So anterior and posterior portions. So just imagine drawing like a curtain straight down on the side of a person from head to toe. Okay, so the section facing you is anterior and the portion behind the curtain is posterior. This plane is especially useful when describing burns, traumas, contusions. For example, a posterior thoracic abrasion. It clearly refers to the back of the chest, okay? Now, next we have the sagittal plane. This is going to run vertical, but instead of front and back, it divides the body into left and right portions, okay? Now, with that in mind, there's also a special version of this called mid-sagittal or midline planes, and that's going to divide the body into equal left and right halves, okay? So this concept is particularly important in like neuroanatomy and trauma. Like if you're assessing a penetrating injury near the midline, your concern increases because it may affect like critical like midline structures like the spinal cord, the trachea, any major blood vessels. Then lastly, we have the transverse or the axial plane. Okay, this is going to slice the body horizontally, creating a superior or top and inferior bottom half. So think of it more like a CT scan image. Each slice is a cross section from the axial plane. It's kind of like a bird's eye view, okay? So this is really helpful for locating abdominal or spinal trauma. So saying a wound is inferior to the umbilicus is going to give us like real immediate clarity, okay? And that's kind of, as we talked about, the importance of medical terminology. It just gives you so much more precision. So these planes really not only serve as guides for EMS documentation, but it also kind of underpins how we visualize the body's layout during assessment and treatment. The more fluent you become with these planes, the more precise and really overall professional your communication will end up being. So here we have a good visual representation of the body's three major planes, right? So we have the coronal, the sagittal, and the transverse. And of course, the mid-sagittal plane is highlighted as kind of like a subtype of the sagittal, okay? This image should help anchor the terminology we discussed in the last slide. So it can be easily for you to visualize during assessments in the field, okay? So let's take a moment and kind of like mentally apply these planes to actual patient scenarios. Let's look at the coronal or frontal plane. So as you see in the illustration, it divides the body into front and back halves. So this is going to come into play when describing a patient who presents with like an anterior chest trauma, for example, like a gunshot wound to the front of the chest, okay, versus posterior findings like a decubitus ulcer on the back in a bedbound patient. The sagittal or lateral plane divides the body into left and right halves. You'll use this when documenting findings like left-sided weakness in a stroke patient. But don't confuse it with mid-sagittal plane, which is strictly the exact midline, okay? That's splitting the body into equal left and right halves. Like when you perform a central chest compression during CPR or palpate the trachea to assess for deviation. Then we have the transverse or axial plane. Again, that's shown as a horizontal division, and that's commonly referencing diagnostic imaging, such as CT scans, but it can also apply when describing injuries and assessments. Like a stab wound superior to the umbilicus is going to suggest a different organ involvement than one inferior to it. As a result, use of anatomic planes makes your communication objective and reproducible, okay? It allows every healthcare provider who reads your charts or hears your radio report or receives your handoff to really visualize exactly where and what you're referring to. So this kind of precision is not really optional in emergency care. It's what prevents miscommunications and really ultimately is going to save lives. So now let's go ahead and look at how the smallest unit of the body, the cell, scales upward to form the organs and systems. So here we begin our journey into the hierarchy of the human body, okay? So from its most basic building blocks, the cell, okay, to more complex organ systems that kind of sustain our everyday life. So as an EMT, you're often assessing organ level dysfunction, but really to truly understand what's going wrong in a patient's body, it helps you start at the cellular level. All these living tissues begin with cells, okay, which are the smallest units capable of performing life-saving activities. So each cell carries out essential functions like metabolism, energy production, waste removal. So when oxygen and nutrients are delivered efficiently to these cells and waste products are removed, the body thrives, right? That's how we function. But when perfusion is compromised, as in like shock, respiratory failure, cellular function begins to deteriorate almost immediately. So that's why it's so much. That's why so much of emergency medicine is about preserving and restoring what we call cellular homeostasis. Cells with and then now with cells with similar structures and functions, when they group together, they're gonna, and they have the similar functions, they're gonna form what we call tissues, right? So there are four primary types of tissues. We have epithelial, which covers the surfaces, connective, which supports and binds, muscles, which produce movement, and then nervous tissue, which transmits pulses. So when you assess skin damage in a burn victim or apply a tourniquet to like control bleeding from muscle tissue, you're interacting with all these different structural units, okay? Then we have organs, right? Organs are comprised of multiple tissues multiple tissue types working together to carry out specific functions. For example, the heart, right? So the heart combines muscle tissues, nervous tissues, epithelial linings to pump blood and regulate the rhythm. This organ doesn't work in really isolation. It's part of the cardiovascular system, which is one of the several organ systems that we'll talk about throughout this chapter. But think of the human body like a corporation, like a business. Cells are the workers, tissues are the departments, organs are the divisions, and organ systems are like the branches, right? So all coordinated towards the shared goal of keeping the organism alive and functioning. In EMS, especially as an EMT, when one system fails, others often will follow. So understanding these interconnections is kind of key to predicting complications and really going to guide your treatment. So with the cellular foundation in place, I think we're ready to move on to our first. So most people think of bones simply as, the hard framework of the body. But as an EMT, you'll quickly learn that the skeletal system does far more than just give the body its shape, right? It plays really a critical role in protection, movement, blood production, and really metabolic function. So let's look at the core functions, right? So the skeletal system does provide structural support, right? By allowing the body to maintain its shape, to bear weight. It forms the framework upon which muscles act to produce movement. But more than that, bones protect vital organs. Like think of the skull encasing the brain, the thoracic cage and the ribs shielding the heart and lungs, or just the vertebrae surrounding the spinal cord. In trauma, this protective role becomes front and center in your patient care. So there are 206 bones in the adult body, and they're categorized into two main regions, all right? We have the axial skeleton and the appendicular skeleton. The axial skeleton is the kind of the central structure. It includes the skull, the spine, and the sternum, and it's really responsible for protecting the central nervous system and all the vital organs in the thoracic cage. And then we have on the other side the appendicular skeleton. This includes your arms, your legs, your pelvis, and your shoulder girdle. It's all about movement, leverage, mobility, the parts of the body that help us walk, lift, and really just be able to interact and manipulate our environment. It's also important to remember that bones are not just static structures, right? So inside many of them is what we call bone marrow. Particularly, we're going to look at red marrow, which is responsible for producing red blood cells, white blood cells, platelets, all essential for oxygen delivery, your immune defense, and clotting. So this makes the skeletal system both a mechanical and a biological powerhouse. So as EMTs, we often are going to encounter skeletal injuries like fractures, dislocations, spinal trauma. But the real skill here lies in the recognition of systemic consequences, right? A fractured pelvis isn't just a broken bone. It's a possible source of a life-threatening internal bleed. A rib fracture may impair ventilation. A spinal injury may affect neurological function. So this is why we really must approach every bone, every joint with an eye, not only for mechanical damage, but also for how it may impact the system it supports or protects. So the axial skeleton, we'll just do another quick little review, forms the central kind of axis of the body. So it is the core support structure that everything else will build from and kind of anchors to. It consists again of the skull, the facial bones, thoracic cage, and the vertebral column. Again, these aren't just structural though, but they do serve as a protective housing for some, again, the most vital and vulnerable systems in the human body. So let's go ahead and start at the top. So we have the skull, right? The skull protects the brain, which is the control center of the entire nervous system. The facial bones from the framework of the face includes critical features such as the orbits or your eye sockets, the maxilla and mandible, which is your upper and lower jaw that house your upper and lower teeth. Beneath the base of the skull lies the foramen magnum, which is just a large opening through which the spinal cord can actually pass and connect to the brain and the rest of the nervous system. So this is a key anatomical landmark when assessing trauma and head injuries. Moving forward, we're going to look at the thoracic cage, and it's made of 12 pairs of ribs, the sternum, 12 thoracic vertebrae, and these protect the heart, the lungs, the major blood vessels like the vena cava and the aorta. It also plays a critical role in ventilations. The ribs expand and contract with the help of the intercostal muscles to draw air into the lungs. So damage to this region, such as a flail chest or a sternal fracture, can really compromise a patient's ability to breathe and maintain adequate oxygenation. Then we have the vertebral column or the spine. So this structure itself is divided into 5 regions. And again, we're going to be kind of redundant here because this whole chapter really could be expanded for multiple semesters, okay? And we're just going to do it in one little lesson, okay? So it's going to get fairly repetitive throughout, but I digress. So let's go back. So the vertebral column, right? So it's divided into 5 separate divisions or regions. Starting at the top, you have the cervical vertebrae. So that's 7 individual vertebrae. Going more inferior, you have the thoracic, which includes 12 vertebrae. The lumbar section, which has 5. Then the sacrum, which has about 4 to 5 fused together, and then the coccyx also has about 4 fused ones together. But each section has really distinct clinical significance, right? The cervical spine is really mobile. It allows for a lot of movement, but it's particularly vulnerable to trauma, especially in motor vehicle collisions or falls. You have the lumbar spine, which bears most of the body's actual weight and is really a common site for chronic pain and acute injury. Then you have the sacrum and the coccyx, right? So this helps form the pelvic structure and provides attachment points for various ligaments and muscles. The axial skeleton really is more than just a collection of bones, right? We kind of been hitting on that. It's a protective column. It's a ventilatory assistant and a neural pathway kind of protector. So when any part of this is compromised, the consequences really can be devastating, all the way from respiratory failure to full-on paralysis. So let's keep it moving. Joints, right? So joints themselves are connective points between bones. They're really essential for movement, stability, and just overall structural integrity. Without joints, our skeletons would just be a rigid framework, capable of bearing weight, but really incapable of any type of functional motion. So as EMTs, it's important to understand joints and how critical they are, because they're often the site of dislocations, fractures, sprains, and with all that in mind, it's just immobilization. So an important concept to grasp is that joints are not all created equal. Some allow for wide ranges of motion, while others are really overall immobile, right? So they're not going to move, and it's all about stability. So what they all share, however, is really a basic structure. It's where 2 or more bones have a meeting, they meet together at a junction, and they're really supported by a network of connective tissue. So each joint we have is going to be surrounded by a joint capsule, okay, or at least a lot of the joints we have. And this is a fibrous sac that encases and stabilizes the joint. So inside of this capsule is what we call a synovial membrane, which produces a synovial fluid, which is kind of like a slick oil-like substance that lubricates the joint, allows for smooth, pain-free movement. So where bones come together, their ends are typically covered with what we call like an articular cartilage or a hyaline cartilage. And that is a smooth, pearly white tissue that reduces friction, and it provides some level of cushioning during impactful movement. Now, some of these tissues that help support them are ligaments, okay? So ligaments connect bone to bone. And then we have tendons, which connect muscle to bone. But these different structures sometimes are easy to confuse each other, but especially when documenting musculoskeletal injuries, and can lead to miscommunication. So it's important to kind of memorize the definition. But let's look at ligament injuries, right? So like an anterior cruciate ligament tear in the knee. So this involves joint instability, right? Because as we talked about, all these different muscle tendons and ligaments, they kind of help stabilize the joint. And then where tendon injuries, like a ruptured Achilles, is going to impair movement, right? So ligaments are more there for stability, while muscle tendons are more there for motion and movement. Some joints, like those in the skull, like the sutures in the skull, those are fused together and immobile. So they offer protection and stability over the ability of movement. Others like the shoulder and the knee, they're highly mobile, and that makes them more vulnerable to actually injury. So you'll learn to assess joint injuries by evaluating range of motion, deformity, swelling, stability, all informed by your understanding of the underlying anatomy. So now that we've laid the structural foundation of what a joint is, let's look at the two primary types of joints that you'll encounter most often as an EMT. And those are going to be your ball and socket joints and your hinge joints. So along with how their anatomy relates to injury and your overall patient assessment. So first, the ball and socket joint, this really allows for the widest ranges of motion. These joints consist of kind of a rounded head of one bone fitting into a cup-like socket of another. The classic examples of this is going to be your shoulder and your hip joints. In the shoulder, you have the humeral head, and it articulates with the shallow glenoid fossa of the scapula. This configuration specifically is going to allow for flexion, extension, abduction, adduction, rotation, external, internal rotation, and circumduction. So think about how you can rotate your arm in almost every single direction. So it's great, but however, this mobility does come at a cost. The shoulder itself, because of this mobility, is highly susceptible to dislocation, especially anteriorly, because it's supported more by soft tissue than any deep bony structures. So this is one reason shoulder dislocations are so common in falls and sports injuries. Then we have the hip joint, right? So it's also a ball and socket joint, but it's far more stable because of the acetabellum, which is the socket inside the pelvis. It's deeper, more reinforced by stronger ligaments and musculature. Hip dislocations, therefore, usually require like a high energy type trauma, like a motor vehicle collision, and they're often come with associated injuries such as like pelvic fractures or some type of vascular compromise. Now let's go ahead and look at the hinge joints, right? Which this is going to allow for motion in only really one plane, and that's going to be flexion and extension, okay? The most familiar examples are going to be the elbow, the knee, and the finger joints, okay? In these joints, the bones articulate in a way that's really going to mimic the hinge of a door. They open and they close along a fixed axis. While design really provides a lot of stability, it also limits the movement, okay, which can lead to injury if the joint is ever forced beyond its natural range. Think of like a hyperextension injury in athletes, or an elderly individual who falls with an outstretched arm. The elbow or the wrist is particularly vulnerable in these cases. All right. A key clinical takeaway is this. So when joints move beyond their designated or designed limits, one of two things are going to happen: either the bone fractures or the supporting soft tissues like the capsule, the ligaments, or the tendon are going to tear. As an EMT, you won't be diagnosing ligament damage in the field, but you are expected to be able to recognize deformity, recognize instability, or just recognize the reduced range of motion. And it's going to tell you that there is internal disruption, right? And your job is going to be to immobilize that as to prevent further injury, further damage, and further pain for the patient. So by understanding the structures and the functions of these different joint types, you'll be better equipped to assess injuries, stabilize them properly, and really anticipate associated complications such as damage, nerve damage, vascular compromise, or any type of hidden fracture. So now let's kind of take a deeper look at the skull, right? The skull is one of the most real critically important structures in the human body and in EMS. It's also one of the most vulnerable in trauma, right? Its primary role is specific to protection, right? The skull forms a kind of a rigid shell around the brain, shielding the organ from external forces. But it's really not a single bone, right? In fact, the skull is made of 28 individual bones, and they're organized kind of into three major groups, right? You have the cranium, the facial bones, and the auditory ossicles, right? And those are going to be the tiny bones in the middle ear. But let's focus on the cranium itself. So this is the part that actually encases the brain. This is going to include the frontal bone, the parietal, the temporal, the occiput, and the sphenoid and ethmoid bones. So these bones are joined by what I mentioned earlier, sutures. So these are immovable fibrous joints that fuse really early in life development. The frontal bones are going to form the forehead, the parietal forms the side and the roof of the head, the occiput or the occipital bone forms the back and base of the skull, and then the temporal bones house the structures of the inner and middle ear, which is going to be very important for balance and hearing. So one especially important anatomical feature is going to be the foramen magnum. Again, this is going to be located at the base of the occiput. It's really just a large opening that's going to allow the brainstem to exit the skull and connect with the spinal cord. In head and neck traumas, really any force strong enough to impact this region like a diving injury or some type of high-speed crash, it really can have devastating neurological consequences. So as an EMT, your awareness of this connection guides careful spinal motion protocols, right? Or what we call SMR protocols during extrication or transport. Next, we have the facial bones, right? So this includes the maxilla, which is the upper jaw, the mandible, which is the lower jaw, the zygomatic bones or zygomas, which is the cheekbones, and the nasal bones, which and all these form the structures of the actual face. These bones are also closely associated with the airway, oral cavity, visual systems. So, for example, like the trauma to the mandible or the zygomatic arch really can impede the airway patency, making it difficult for the patient to breathe or to speak. And this is the key reason why you really have to assess for facial instability and crepitus in any trauma involving the head or the face. Finally, let's look at the orbit, right, or the eye socket. This is actually formed by multiple bones, but it provides protection for the eye. But it is relatively fragile, so any type of blunt trauma to the face from an assault, a fall, or a sports injury, it can cause orbital fractures. And this often presents with signs like a preorbital ecchymosis, double vision, impaired eye movement. So understanding the anatomy of the skull allows you to approach head injuries with just more precision, and it's going to help you evaluate symptoms like unequal pupils, bleeding from the ears or nose, or any type of altered mental status, with just a deeper insight into what may be happening beneath the surface. Again, we have the spinal column or the vertebral column. This is really the central supporting structure of the body and one of the more critical to assess and protect in any trauma scenario. It serves three primary functions, okay? It protects the spinal cord, it supports the weight of the upper body, and it does allow for flexibility and movement. So despite its strength, the spine actually is surprisingly vulnerable, right? Especially in any type of high energy trauma like falls or car crashes, or any type of blunt trauma to the head or the neck. But the spine itself is composed of 33 individual vertebrae, okay? And it's organized into five divisions, right? So we talked about the cervical vertebrae, and that's gonna be what we call C1 through C7. So these 7 vertebrae form the neck. The first cervical vertebrae has a special name. We call that the atlas, and it supports the skull. The second, or C2 vertebrae, is the axis, and this allows for rotation of the head. This region is especially delicate, and the common injuries in this area are whiplash, diving accidents, and hanging injuries. Always suspect a cervical spine injury in any patient with head trauma or altered mental status. Next, moving down, we have the thoracic vertebrae in that division, and we would label those as T1 to T12. So these 12 vertebrae anchor the ribs and kind of form the upper back. Each thoracic vertebrae is connected to a pair of ribs, making this specific segment relatively less mobile but highly protective of the heart, lungs, and the great vessels. So any injury here may also be associated with rib fractures, flail chest, or possibly internal bleeding. Then we have the lumbar spine, L1 through L5. This region supports most of the upper body's weight. It allows for bending, twisting motions. It's often injured in lifting accidents or when you have a patient who falls and lands directly on their buttocks. Because the spinal cord ends at the kind of the L1, L2 region, injuries here may actually damage what's called the quadra equina, resulting in urinary incontinence, leg weakness, or numbness in the perineum, which is really a red flag that's going to require special spinal imaging. Next we have sacrum, which is going to be S1 to S5, and it's really going to be these 5 specific vertebrae are fused together to make one single bony mass, and it's going to connect the spine to the pelvic girdle, and it's going to make the posterior aspect of the pelvis. So injuries here often are accompanied by pelvic fractures, which really can be a life-threatening injuries due to hemorrhaging. Because of all the major vessels in the pelvic area. And then lastly, we have the coccyx, and this is going to be formed by the fusion of 4 tiny vertebrae. This serves as a minor point of muscle attachment. Though less clinically significant in trauma, the coccygeal injuries are often seen in low impact falls, especially in our elderly patients. But anyways, between each of these vertebrae are what we call intervertebral discs. Okay, so these intervertebral discs are really strong cartilaginous shock absorbers, and so it's going to allow for the flexibility and cushioning of the spine. When one of these discs are actually compressed or ruptured, we call this a herniated disc, and it can actually press on a spinal nerve, causing pain, numbness, and possibly paralysis. So the spinal cord itself, or the spinal column rather itself, is stabilized by ligaments, okay? So just like a lot of our other joints and bones, stabilized by ligaments and muscles. But the way it's aligned is really what's important here. So any shift in the vertebrae, even just in like millimeters, can compromise the spinal cord, and this could really lead to permanent neurological damage. And that's why SMR, spinal motion restriction, is really a standard for any trauma patient with a suspected spinal injury, coupled with like altered mental status or some type of distracting injuries. So remember, as EMTs, your job is really not to diagnose a spinal injury or any injury. It's really to assume it exists, right? So we always want to think worst case scenario when it's appropriate. And your job is to take immediate steps simply just to prevent further harm. Next we have the thorax. So this is commonly known as just like the chest cavity. It's one of the most vital regions of the human body because it houses and protects some of the most critical organs in your entire body. Your heart, your lungs, your great vessels like your aorta and the vena cava. And you also have in this little region the esophagus, right, and the trachea. So as EMTs, you will assess this area on nearly every single patient you have. Okay, from just having a chest pain or to blunt trauma, an understanding of this anatomy is really essential for identifying any type of life-threatening conditions, especially to the internal organs. So like a tension pneumothorax, a pericardial tamponade, or a cardiac tamponade, flail chest. The thoracic cage itself is made up of 12 thoracic vertebrae on the posterior aspect. It has 12 pairs of ribs and the sternum on the anterior aspect. Each rib is attached posteriorly to a thoracic vertebrae, and most connect anteriorly to the sternum through cartilage, which allows for expansion and contraction of the chest during breathing. Okay. The ribs themselves form kind of like a semi-rigid structure that is strong enough to protect organs, but also flexible enough to move with each of the breaths you take. The lower two pairs of ribs are going to be known as floating ribs, okay? And they're not connected to the sternum, and they're definitely way more vulnerable to injuries. Then we have at the center of the thorax lies the sternum, or it's going to be commonly known as the breastbone, which has three main parts. So at the very top, we have something called the manubrium. This is the upper portion that's going to connect the clavicles and the first ribs. You can palpate the sternal notch and its superior border, which is going to be like a useful landmark for CPR hand placement and just assessing jugular vein distension. You then have the body of the sternum, which is the longest part, providing attachment for the major ribs. And then lastly, at the very bottom, you have the xiphoid process, which is just a small cartilaginous kind of extension at the most inferior end of the sternum. This part actually can be easily fractured during improper chest compressions, which is why EMTs are trained to avoid placing too much pressure on the lower half of the sternum during CPR. So within this thoracic cavity, you have what's called a pleural space that surrounds the lungs. You have the mediastinum contains the heart and the trachea, and then the diaphragm really marks the inferior border, okay? So trauma to this region can cause life-threatening disruptions to breathing, to circulation. An example, like having a penetrating trauma or injury might actually puncture the lung, causing a hemothorax or a pneumothorax. Blunt trauma may fracture ribs, impairing ventilation or lacerating internal organs. It's also worth noting that the thorax is very dynamic. It moves with every single breath and heartbeat. So when you're evaluating these injuries, you really have to look at the asymmetry of the chest rise. You're looking for paradoxical chest motions, crepitus, any open wounds, because all of these can signal like a significant compromise. Also in this area, whether you're like placing ECG leads, performing CPR, or listening for breath sounds, your familiarity with the thoracic anatomy ensures your interventions are going to be safe, accurate, and potentially life-saving.